Now, this is normal, of course, we said this already, but let's look at other kind, or let's say, let's apply what I showed you before in terms of normal anatomy to pathological abnormalities. And the first group I would like to explore is the posterior fossa cystic malformation. Now, we have two kinds of cystic malformation here. One is a 6-year-old male with developmental delay and shunted hydrocephalus. So he had hydrocephalus. And here what we have is basically that in this case, also there is a cystic malformation, but in this case, the appearance of the vermis here are a bit different, and the hydrocephalus has not been shunted, so is still present. Now, these are two cystic malformations of the posterior fossa, but they are completely different. What are the differences? So, first of all, the vermis here is, sorry, there is something on the chat. Okay, so the vermis here is hypoplastic, so is small and is rotated, okay? And the fastigium, so this acute angle you saw before, and here is preserved, in this case is flattened, okay? So what we have is hypoplastic rotated vermis, dilatation of the fourth ventricle with flattened fastigium here with the asterisk, and then an enlarged posterior fossa with associated hydrocephalus that in this case was shunted. This is the definition. These three radiological and pathological characteristics of the posterior fossa are typical of the Dandy-Walker malformation. Now, this other case is not a Dandy-Walker malformation. What we have is that the vermis is normal in size, maybe a bit rotated. There is a bit of enlargement of the inferior part of the fourth ventricle, but the fastigium is present and is acute. So it's normal at the midpoint of the fourth ventricle and is acute. The fourth ventricle is dilated in this case, and the posterior fossa has a normal size. Look at the size of the posterior fossa here. Now, this is the definition of Blake pouch cyst. The difference between a Blake pouch cyst and a Dandy-Walker malformation is in fact the vermis, and this is relevant not only for your diagnosis but also for the prognosis, because a small abnormal vermis means that the prognosis is not good. Now, both can have hydrocephalus, remember that, but look at the vermis, because the vermis is the main differential. And you need to know how the vermis is done, how it's composed anatomically. There are 9 lobules that are the lingula, and then clockwise central lobule, culmen, and then there is the primary fissure, and then the declive, folium, tuber, and then another fissure called pyramidal fissure, pyramids, and uvula. And this is the normal appearance. If something is missing, the cerebellum is, the vermis is small, think of Dandy-Walker malformation. And of course, the kind of sequence you do is very, very important. So you need to do, if possible, 3D T1 weighted images, because you need high resolution. Now, other two cystic malformation of the posterior fossa are these two that are not really relevant by the clinical point of view. One is the posterior fossa arachnoid cyst, and another is the megacisterna magna. Now, both of them, like the Blake pouch cyst, they have a normal vermis. The difference is that in the Blake pouch cyst, there was this enlargement of the fourth ventricle, and there is often hydrocephalus. Now, if you look at these two papers, both in the same journal, is I think Clinical North America, you have this very, very good table where you can see the difference between Dandy-Walker malformation, Blake pouch cyst, megacisterna magna, and posterior fossa arachnoid cyst. The only one with hypoplastic vermis that is also rotated with flattened fastigium, so profound malformed, is the dandy Walker malformation. The others, they have normal vermis. The difference between plaque pouch cyst and the other malformation is that in the plaque pouch cyst, the fourth ventricle is enlarged. Now, the reason why this is enlarged is because during the development, this plaque pouch should perforate and allow the vermis and the cerebellum to close along the brainstem, so create the shape of the fourth ventricle. When this doesn't happen, you will have this persistent plaque pouch cyst, and you can have hydrocephalus in a lot of cases, not all of them, but in a lot of cases. Now, there is also another entity that is very interesting, and it's called so-called inferior vermis hypoplasia. Now, this inferior vermis hypoplasia, this is again from the paper from Maria Sarina Severino and Terry Huseman, which is a recent paper that I will share with you. Inferior vermis hypoplasia is a situation where the vermis is small. And the fourth ventricle can be normal, can be slightly enlarged, but the rest is normal. Now, this is an example. This is for another paper on posterior fossa malformation. It's full of paper out there about posterior fossa malformation, but what I'm trying to do is just a good summary for you guys. And this is an isolated inferior vermin hypoplasia. Published by Pozzemani, who is an expert. I have to say that looking at something like that, I may also report normal. And this is another case of a case series that we are studying with some neurogenetists of Diaz-Logan syndrome, and you have here vermis hypoplasia and slightly enlarged fourth ventricle. The pons may be also slightly smaller, but you can see from these two cases how difficult it is to call something verminal hypoplasia. So in this case, I don't like measurement very much in radiology because it can be misleading, but in this case, you may want to use measurement. And this is very interesting papers. Again, I will send this to Daria, so you will have the references. And basically, they take a lot of measurement in the posterior fossa, but the most important is this one, craniocaudal vermis diameter. And they have different values divided by age and sex, and this is the vermian high. So this measurement here, and you have neurogenetic patient or a suspected neurogenetic condition. You look at the vermis, the rest is fine. There is no dandy Walker, there is no black pouch cyst. You look at the vermis, it looks a bit smaller. Use this measurement and confirm your finding. That's very, very important. Now, another important thing is to look at the differences between hypoplasia and atrophy. So when we use hypoplasia and when we use atrophy. Now, these are three cases, so three columns with three different children. Let's start from this one. The cerebellum here is clearly asymmetric. This hemisphere looks okay. This other hemisphere look actually quite small, almost absent. Okay. Now, how you reported that and what this finding means. This is 4-year female with squint, nothing else. Now, this is a unilateral cerebellar hypoplasia, and what is very important in the unilateral cerebellar hypoplasia is that most of the time you can give to the clinician a diagnosis. So this is called unilateral cerebellar hypoplasia. It's non-progressive, and important is, and this is the original Poretti definition of hypoplasia, the important thing is that in the hypoplasia, differently from atrophy, the fissures are not wide. So the cerebellum can be very, very small, but you see there is no widening of the fissures, so the cerebellum is not atrophic. And importantly, most of the time, this is an insult that happened prenatally, and this may have a relevance when it comes to medical legal problems. And they say that it's between the 18th and 24th weeks of gestation. So you see something like that, you give a diagnosis that is precise, and you also give to the clinician an explanation for the findings. This is a global bilateral cerebellar hypoplasia, and again, you can see the cerebellum is clearly small, but there is no widening of the sulci. Global cerebellar or bilateral cerebellar hypoplasia is a global reduction of the volume of the hemisphere and vermis, but normal shape, without widening of the fissure, because when there is widening of the fissure, we call it atrophy. In this case, consider congenital infection or sometimes a neurogenetic disorder. And this is how the atrophy looks like, and you can see the difference. Now, another thing that they say in the book is the atrophy, so to call something atrophy needs to be progressive. However, take in mind that some of the atrophy, cerebellar atrophies, are not progressive. This is another case. Clearly, both vermis and cerebellar hemispheres are atrophic. Now, this is 23-month boy with hypoglycemia at birth, but this is clearly a neurogenetic problem because the abnormalities are isolated in the cerebellum, and in this case were also progressive. Now, this is when you see something like that, so you see just atrophic cerebellum and nothing else in the supratentorial brain or in the brainstem, you call it isolated cerebellar atrophy. And this was a patient with a disease, it's called congenital glycosylation disorder, but actually there are a lot of causes for pure cerebellar atrophy. So what you need to tell your clinician is, this is a pure cerebellar atrophy, do the cerebellar atrophy panel. We cannot go deeper than that in our origin, in our diagnostic thinking. So in this case, it's progressive, there is a widening of the fissure, and there is a wide differential. So normally, this is a neurogenetic condition. Rarely, there are some neurogenetic conditions that are not progressive as well, so this can be misleading. But it's important that you at least understand what's the difference radiologically between atrophy and what we call hypoplasia. This is another interesting paper from Poretti. It's about the cerebellar atrophy, and here you can see they divide the different kind of cerebellar atrophy according to the associated or absence of associated finding. If you have only cerebellar atrophy, you call it pure cerebellar atrophy, and there are a lot of disease that can present like that. If you have something else like hypomyelination and cerebellar atrophy, what you have a bunch of other disease. Finally, if you have, for instance, there are different kind of things, but this is quite important, cerebellar atrophy with this very, very bright cortex in flare points toward another class, another a group of abnormalities. Of course, some of them are overlapping, but at least it's a starting point for the clinician. And this is the name of the paper, which is free to download in ResearchGate. Now, the problem we have is when we start to speak about pontocerebellar hypoplasia. Now, pontocerebellar hypoplasia is actually is a group of disease, of genetic disease that are actually characterized by pontocerebellar atrophy, not hypoplasia. And they normally involve cerebellum and pons, but not only cerebellum and pons. We have 11 types of so-called pontocerebellar hypoplasia, can have non-progressive course that again can be misleading. And the most important thing that you can do as a radiologist, first of all, identify that this is a pontocerebellar hypoplasia, and then try to distinguish between so-called dragonfly or global pattern. What is the difference? This is a dragonfly pattern. You see that the vermis is quite normal. Pons is small, but look how atrophic are the cerebellar hemispheres. In this case, when you see something like that, you call it a dragonfly pontocerebellar hypoplasia, and you point the clinician toward this direction. And you cannot go further than that, apart from some cases that I will show you. but at least they know that they need to explore this class of disease. So pontocerebellar hypoplasia are actually pontocerebellar atrophic pictures that are most of the time, but not always, progressive, and they are characterized by these two patterns: dragonfly, and this is a global atrophy where both, you see the difference in coronal in the vermis, both the vermis and the hemispheres are atrophic, and you see the difference here in sagittal, a very small atrophic vermis, um, and a normal vermis in the dragonfly. So this one, we call it dragonfly, and this is a global cerebellar atrophy. This is basically a table from the same paper that I'm quoting a lot because it's an excellent paper from Severino and Huseman, about pontocerebellar hypoplasia subtypes. But remember that this is not your job to do a genetic diagnosis, also because some pontocerebellar hypoplasia, like the type 4 or type 5, actually they have the same gene. And the type 2 also have SEN54. So you don't want to do a precise genetic diagnosis, but what you need to do is at least to recognize that this is a pontocerebellar hypoplasia pattern and ask for the panel. There are sometimes you can go further. Look at these cases. This is a paper that we recently published with Elisa Scola, who is from a neuroradiologist from Milan, and you can see there are some characteristics in these patients. First of all, there is a progressive cerebellar atrophy of a dragonfly pattern. Look at this. This is the image I showed you before, but also here the vermis is preserved. In all three patients, the size of the vermis is quite bulky in comparison to the massive reduction in the size of the cerebellar hemisphere. So first of all, you have a dragonfly pontocerebellar atrophy. Look at the pons, is very small. And then you have a very small, almost invisible corpus callosum, a PVL, that means periventricular leukomalacia, so massive loss of white matter that normally we used to call PVL white matter injury of prematurity. So these preterm babies, they have a massive loss of white matter, and we say, okay, this has to be a problem at birth in a preterm infant. But this is not the case. This is progressive, and this PVL was present in the fetal brain, was present at birth without any significant perinatal event, and progressed over time. Finally, if you look at the midbrain in axial, you have this characteristic shape of 8 here, sometimes less evident, but you see here there is this 8 shape. So this very abnormal brain in axial. And this now we started to connect with the original picture of Mick Jagger, because we have a constellation of findings. We add a lot of elements to this picture, apart from the pontocerebellar hypoplasia. We know that this is a pontocerebellar hypoplasia. We know that this is abnormal posterior fossa, but we know also that this is a dragonfly, that this is associated with PBL, thin corpus callosum, and this strange midbrain in axial. Altogether, this is typical of one gene only. This is AMPD2 mutation, and this is one subgroup of pontocerebellar hypoplasia called pontocerebellar hypoplasia type 9. So in this case, you can go to the clinician and say, you don't need to do a panel. This is a progressive condition. The constellation of findings is very typical. So basically, you need to test just this gene. Now, another important thing you can do, and please they send me a message if everyone can mute their own audio, because there is a problem with the sound. So if you can all just mute your audio. Please, can everyone mute their own audio? So we don't hear any sound. Thanks. Okay, so now another thing you can do in terms of this looking for constellation of findings that I like very much is the presence of cysts. So we look for basically presence of other associated findings. So in these three cases, three column, you have cysts in the cerebellar hemispheres. And then, so you identify something wrong in the cerebellum, so the presence of cysts, and then you start to add other elements. Now, in this case, in the center, what you have is just cerebellar cyst, this abnormal squared fourth ventricle, and nothing else. So cerebrum, so the brain, supratentorial brain, is normal. When you have cerebellar cyst, this strange shape of the fourth ventricle, but nothing else in the supratentorial brain, think of this LAMA1 mutation. They have a problem in the motor problem in the eyes, and this is again a very specific constellation of findings. Let's look at this other case. We have again cerebellar cyst, but in this case, the rest of the brain is very abnormal as well. We have this lissencephaly that we call cobblestone lissencephaly. You see normal cortex, and look at how abnormal it is here. And also this Z-shaped, completely abnormal brainstem. So because of this constellation of findings, we know that this is a congenital muscle dystrophy. And this is, again, a very typical constellation of findings. So you need to recognize that. While in this other case, we just have two things, cysts and bilateral polymicrogyria. So you see this hemisphere are very small and quite abnormal. And this is another gene, is GPR56. Now, you don't need to do all this diagnosis because, of course, these are very rare and so on. But what I want to stress is the fact that you need to decide where to start. Like cerebellum is abnormal, and how is abnormal? There are cysts. And then you add things. Here there is nothing else. Here there is Z-shaped brainstem and a malformation of the cortex. Here there is another kind of malformation of the cortex. So you put things all together and you can actually try to attempt the diagnosis. This paper is the one that I show you at the beginning of the lecture. I will share this as well and will show you in details all this malformation. Now, again, let's start with another pattern recognition. This is a 2-year child which is deaf, first of all, and then so cannot hear much and has this perinatal history of difficulty in swallowing. Okay? Now look at the brainstem and remember the normal brainstem as I showed you before. So in this case, here, you have this hunchback pons, and the pons is very flattened anteriorly. So you have this abnormal shape of the pons. Probably the cerebellum is also abnormal. And if we look at the inner ear, you see that there is this strange shape of the inner ear with dilatation of the vestibular aqueduct and cochlear hypoplasia. So you have abnormal pons, but this abnormality of the pons with flattening anteriorly and protrusion posteriorly is again extremely specific. And if we do color mapping DTI, this is very, very important. That when you have a cerebral malformation, if you are lucky enough to have a DTI program in your MR system and you can do a color mapping, you will be able not only to see if the shape is abnormal, but also the course of the fiber within the brainstem and the brain in general. And you can see normally at the level of the pons, you have, so this is an axial section of the pond with the color map DTI. You have these transverse pontine fiber that are red, meaning that they are going right to left, between these descending fibers. Everything that is descending down is like the corticospinal tracts here, or the tegmental tracts are blue. So you have a central red fiber with blue between these descending fibers in blue. Look at our patient. In our patient, these transverse pontine fibers are misplaced posteriorly in the cerebellum, and this is what we see here with this in this protrusion. So this is a defect in the normal organization of the fibers, and this appearance is extremely typical. And this is important because I did a review 1 month ago on a paper that was sent to a journal, and they called this Pontocerebellar hypoplasia. And I had to say, listen, they were wrong. This is pathognomonic on this that is called pontine tegmental cap dysplasia, PTCD. Now, we don't know what gene is that, but we know that when we see something like that with inner ear abnormality, this shape of the pons, and if we can do DTI color map, this abnormal location of the fiber, we know that this is a pontine tegmental cap dysplasia, and we need to call it like that. Another typical constellation of findings, and then if you have any doubt, I can come back to the slide and we can discuss afterwards. Now, this is 7-day-old with baby with dysmorphic feature, abnormal eye movement, and some, in general, trigeminal signs, okay? And also alopecia. Now look at the cerebellum. Try to remember what I show you as a normal cerebellum. Look, in this case, the two hemispheres are linked together. So there is no vermis in between, and you can follow the foliation all the way right to left. And this is again very typical, almost pathognomonic. This is the control. You can see here there is the vermis in between. So you follow the folia and then it stops at the center. There is the vermis and then folia on the other side. Here, there is no such thing. And this we call rhomboencephalosynapsis. When we have a rhomboencephalosynapsis, so we do the neuroradiological diagnosis, and then we see that there are trigeminal abnormality signs in the clinical history, and we look at the child and we see alopecia, we call it Gomez-Lopez-Hernandez syndrome. So rhomboencephalosynapsis plus scalp alopecia plus trigeminal dysfunction. So you put all together this element to your picture. So do not be focused only on the neuroradiology and only on the posterior fossa. Start from the posterior fossa and include the brain, include the clinical findings, include the other information you have in the clinical history, and you can do a diagnosis of a syndrome, sometimes of a gene. This is another important thing. So first of all, let's focus only on the part of the picture. Let's focus only on this axial and on this sagittal. You have this strange shape of the midbrain, and this very, the thickening of the an horizontal course of the superior cerebellar peduncle. Okay? This looks like a dent, like a molar, and this is what we call molar tooth. And in sagittal, so molar tooth in axial depends on the orientation of the axial, but in sagittal, it will look like that. And of course, we know that there is something wrong in the hands, but something wrong here in the midbrain and corpus callosum, and so on and so on. But let's focus on this. When you see something like that, you call it Joubert. Now, Joubert syndrome is a description of a neuroradiological sign. It's not a diagnosis per se. But you need to recognize, because once you recognize Joubert syndrome, you can put all together the other pieces of the puzzle, neuroradiology, clinical symptoms, plain film, and you can try to narrow down the diagnosis. So this is the molar tooth sign, and this is typical Joubert syndrome. Now, If you, again, in malformation, I think more than pre-surgical planning, in malformation, the DTI with color mapping is very, very, very important because in this case, you see this is a normal child with the normal decussation in red, this red dot here, meaning that the superior cerebellar peduncle are decussating at the level of the midbrain. In a Joubert, you don't have such decussation, but just anteroposterior fibers in green. So remember, the color coding is right, left, red, up, down, blue, and anteroposterior green. So in this case, if you have DTI color map, you confirm your finding of a molar tooth and you confirm that it is a Joubert. Now situation becomes difficult because this is a paper from Enza Maria Valente. You see how many syndromes they have the Joubert sign. So the molar tooth sign of the brain is just a piece of the puzzle. You need to add information about the eye, kidney, liver, orofacial, and so on and so on. Now, all these syndromal ciliopathy, so a problem in the movement of the cilia, all of them, they have multi-organ involvement, and this multi-organ is particularly important when it comes to eyes, liver, skeletal problem, and renal abnormalities. So if you are general radiologist or general pediatric radiologist, you need to think of your plain film or ultrasound when you see kidney ultrasound when you see a Joubert. And again, you put together the pieces of the puzzle. In this case, you have a very, very small vermis, molar tooth, syndactyly, and hypothalamic hamartoma. You look at the tongue and you see some small hamartomas in the tongue. This constellation of findings is typical of orofacial digital syndrome type 6. So you have the molar tooth signs, and then you add things to the picture. Tongue hamartoma, checked. Polydactyly, checked. Hypothalamic hamartoma, checked. And on top of that, remember that the Joubert in this patient is very, very serious because you have a spectrum of Joubert, all characterized by this absent decussation of the superior cerebellar peduncle, all characterized by the molar tooth sign and abnormal vermis. But in this case, as you can see here, for instance, the vermis is extremely atrophic, the pons is abnormal as well, very dysmorphic brainstem. So you put together all the pieces of your neuroradiological puzzle, actually clinical radiological puzzle, and you do the diagnosis. This can be very, very important because it changes a lot in the management of the child. And another example, and these are the last two slides I have, are apart from the one on Mick Jagger, is this constellation of findings. Again, look at the posterior fossa. Remember the original normal anatomy I showed you before, and you will see that this is not normal. So what you have is dysmorphic and asymmetric middle cerebellar peduncle. These are not normal, these are clearly asymmetric. The brainstem is abnormal with the dysmorphic midbrain, the pons is not prominent as it should be, and the vermis is also abnormal. Look at the orientation of the basal ganglia. There are also malformation of the cortex, not very easy to see here, but you see normal cortex here is over convoluted. Sometimes they are very striking and there is lissencephaly. Abnormal corpus callosum, very, very small. This is dysmorphic corpus callosum, and cerebellar hypoplasia and dysplasia. This constellation of findings, so brainstem abnormality, cerebellar abnormality, corpus callosum, abnormally rotated basal ganglia, and malformation of the cortical development are typical of tubulinopathy. Again, you don't need to do the diagnosis of the right gene, tubulin gene, but you can say this constellation of findings involving posterior fossa and cortex and corpus callosum are typical of tubulinopathy. So they will do a panel for tubulinopathy and they will find the gene, and this will change the management of the child. Even more important for the management of the child is a case like that. So this is from Dan Doherty, who is a friend of mine working in Seattle, and this is 1 year male. He is also deaf with very mild motor delay and a prenatal diagnosis of hydrocephalus and small corpus callosum. So they wanted to consider abortion because they say, I cannot see the corpus callosum. There is this large hydrocephalus. What's going on? But actually, uh, you can see again a combination of interesting finding. There is polymicrogyria here. Look at the normal cortex here in this unmyelinated brain that suddenly become very lumpy, bumpy, very crowded here. This is polymicrogyria. But not only polymicrogyria, there is also something here along the ventricle anteriorly that this is abnormal gray matter. We call this periventricular nodular heterotopia. So you have polymicrogyria, nodular heterotopia, again, abnormal corpus callosum, and look at the foliation of the cerebellum is completely irregular. So you have this four abnormality plus the dilatation of the ventricle that is, however, not hydrocephalus. In this case, although there was a cyst and there was some pressure, most of it is due to loss of white matter related to underdevelopment of the corpus callosum. We call it colpocephaly. Now, we have this combination of findings, again, frontal polymicrogyria, nodular heterotopia, partial agenesis of the corpus callosum, colpocephaly, and this very typical, although not present in all the patients, but very typical disfoliation of the cerebellum. This is called Chudley-McCulloch syndrome in a deaf child. Okay, so even in a deaf child, you see this constellation of finding with this strange cerebellum. Think of this syndrome, think of this gene. Why this is so important? Not just because we want to look very bright, but because these children, despite this very wide spectrum of malformation in the brain, they do very well. They are almost normal apart the deafness. So this is very good prognostic factor to do a diagnosis on your scan. So again, I will give you also these slides and a paper from Dan Doherty describing the finding, but remember really this combination, colpocephaly with this strange cerebellum and abnormal corpus callosum associated with malformation of cortical development. So as you could see, if we put together all this, okay. So if you put together all this constellation of different findings, you will do often a good diagnosis. So let's come back to our picture. So this is Mick Jagger in a party in the 60s, very famous with a beautiful girl, but still he looks very sad. So there's something in the picture that doesn't fit very well, and these things that our neurologists tell us will be, let's say, the right hint for the right diagnosis. So why he is so sad, despite he is Mick Jagger, and these are the 60s? Well, actually, because Marianne Faithfull is speaking with Alain Delon, which is also in this party. So this is a joke, but as I showed, it's very important to have all the information you can have to do the right diagnosis. So what are the take-home messages of this lecture? First, you need to know what is normal, and you will know then what is not normal. So remember the relationship in craniocaudal, in sagittal slide, so craniocaudal relationship between the pons, the midbrain, and the medulla oblongata. Remember the difference between cerebellar atrophy and hypoplasia is not always possible to differentiate these two entities, because there is also, as I showed you with pontocerebellar hypoplasia, some problems in nomenclature, but is useful when you can do this differentiation because it implies different diagnosis. Try to connect the dots, so this is a pattern recognition process, and ask a friend. We have neurologists, geneticists, neurometabolic specialists that can add a lot of information to your neuroradiological picture. And remember to look at the bigger picture. Posterior fossa is just a part of the brain, and brain is just a part of the body. And finally, before we start the discussion, this is where I'm from, so the south of Italy. Unfortunately, now I cannot go there because of the coronavirus problems, but it's full of beautiful archaeological sites. So feel free to send me an email also if it's about that, not only neuroradiology. Thank you very much. Okay, so I don't know if someone has some question. Daria, are you there? So if you have some question, you just can unmute your microphone and feel free to speak. As I was saying before, I hope was clear. You can send me an email if you need anything, but I will try to share as much as I can all the meetings we will do. There will be a lot of WebEx and Zoom meetings in the next future. So I hope this was useful. I will share the paper. So I have some questions. So how important is to indicate the type of malformation when there is no hydrocephalus and no treatment is needed? Well, it depends, because so it's important sometimes if this is a prenatal insult or if it's a genetic problem, because if it's a genetic problem, you do need to tell the family, especially if they want to have another child. And there is also prognostication that you can do. If you have just a unilateral cerebellar hypoplasia, this is prenatal problem. It's not going to go worse and will be stable over time and clinically not really relevant. They can have some symptoms, but nothing bad. If you have a pontocerebellar hypoplasia, it can go worse and worse, and the parents need to know. On top of that, these are genetic problems, so you can have problems with your children. So this is why it's important to try to do the diagnosis, but do not try to be too much precise, because you just can tell the clinician, listen, this is genetic, you need to do the panel. Any other question? Okay, so if there are no other questions, hey Ali, how are you? Long time no see. If there are no other questions, I will close the meeting now, and I will send all the both the presentation and the relevant literature to Daria for you to share. Next time we can speak about something else, and there will be another meeting organized by my hospital with someone from Sick Kids, I think next Saturday. So I will let you know. Have a nice day.
Thank you, Felice. I'm sorry I was a little bit out of the chat. I have a great pleasure to thank you, because it was cool lecture, excellent, with good structure, very good structure, because sometimes it looks like a lot of pathology and you cannot gather it. I will share your information in our group in Ukraine. You're very popular because we have 100 participants on this lecture. And we are still waiting for you in Kiev.
All right. Okay. Have a nice day.
Thank you.